Yes, so I'm going to talk about uh, the charity that I'm part of, Transplant Links Community, and also to talk a little bit about uh, transplantation in terms of recipients and donors. Just briefly touching on that, there should be plenty of time for discussion because I'm conscious that people will have questions that perhaps won't be answered by the presentation. So the charity was started by this lady here, Jenny Jewett-Harris, and Mr. Andrew Reddy, who is a transplant surgeon in Birmingham, UK. And it was started in about 2007, and it was really because of a recognition that access to renal replacement therapy in terms of dialysis and transplantation is very unequal around the world. And even though we feel that here in the UK, our resources are limited, we're aware that in other parts of the world, there are people not able to access any form of renal replacement therapy. And so the charity developed to try and improve the situation and decided to concentrate on developing or helping to support kidney transplant programs in low and middle income countries. And really this was because it was recognized that transplantation is very cost effective. The cost of transplantation once you have a successful transplant is very much less than being maintained on dialysis. And the charity is really very lean in the sense that there's a very small administrative staff. It's just these two ladies, Jenny and Amy, who are the full-time sort of administrative team. But it works by linking UK healthcare volunteers and partnering them with local medical nursing staff, transplant coordinators, linking with hospital management, and also trying to engage with with politicians and patient groups where they're present in low and middle income countries. So it's taking volunteers from the UK to work with their colleagues in low and middle income countries to either develop or to progress a transplant program. The first mission was to Ghana in 2008. Here you'll see on the left, this gentleman was on dialysis. You can see he was on hemodialysis, and his wife donated to him. And 10 years later, you can see that he's doing extremely well. He's in full employment, in good health, and his wife is also very well. So that was the first mission, and subsequently the next really big development was linking with Trinidad and Tobago, and in fact that was the start of our involvement with some of the Caribbean islands. And this started in about 2008, where when Dr. Samuels here came to the UK following a contact with Mr. Reddy, who's a transplant surgeon in the UK. And he came here and spent just under 18 months developing his skills in renal transplantation, working alongside the medical staff here, and as I say, developing his skills. And subsequently, there were visits to Trinidad and Tobago from surgeons, nephrologists, nurses, and theatre staff to try and help support the program, which had already started, help develop it further. In addition, transplant coordinators from Trinidad and Tobago have come to the UK and spent time with their counterparts here, learning how things are done in the UK. And going right the way forward to now, this Trinidad and Tobago's has undertaken almost 200 transplants. Initially, almost all live donors. I'll show you some of that data later in a few slides. But more recently, they've started to develop a deceased donor program. And really, this development and our involvement with the National Organ Transplant Unit in Trinidad and Tobago has been made possible by the support of Republic Bank, which has a number of community programs. And one of those elements related to individuals with chronic kidney disease and access to transplantation. When we first were involved with the local team, they had undertaken some transplants. A number of them had been undertaken by visiting Cuban surgeons. But once Dr. Samuels returned, he started undertaking transplants. But where TLC really became involved with two aspects. One was to do with improving donation surgery and helping to develop laparoscopic hand-assisted donor nephrectomy, which is a much smaller operation than the normal operation for removing a kidney. But also we helped in developing their pediatric program. And this is one of the first young children who were transplanted in Trinidad. This young man was 11 or 12 years old at the time, and you will see here that his mother donated to him. And 10 years later, he's doing very well. He's completed a degree, and he is now studying for a master's in community public health and doing very well. So it's been a fantastic achievement for everyone involved, for this young man to have done so very well. And this graph shows you how transplantation has changed in Trinidad and Tobago over time. The green bars are live donors. So you can see that the program started in the early 2000s, where they were doing between 5 and 10 transplants a year. When TRC became involved, the transplant program, as I say, was in existence. But the thrust of our involvement was to help with the donation aspects. The pediatric data is unfortunately not available. I can't show you the pediatric data, but we started doing children in about 2012, 2013. But what this program shows is that as time's gone on, you can see they've now moved to a deceased donor program, and you'll see the purple bars are where transplants are from deceased donors. So as time has gone on, you see a mix of green bars and purple bars. And this is, if you like, a progression of a program to what is now a fully mature program offering live and deceased donation to the population. I said TLC's been involved in the Caribbean, and one of the other islands that we went to is Jamaica. We were involved initially in Kingston, and then more recently in Cornwall Regional Hospital. And again, the format was similar in that teams from the UK visited the centers in Jamaica, reviewed potential recipient and donor pairs, talked with the local team about investigations that needed to be done, things that needed to be carried out before a successful transplant could be undertaken. And then subsequently a mission was arranged where a surgical team with theatre nursing support and medical support visited Jamaica and undertook a number of transplants that were planned over a period of time. And the next phase was for clinicians from Jamaica to visit the UK. And just as happened with the team from Trinidad, we've had surgeons, nephrologists, and transplant coordinators spend time in the UK being exposed to a mature transplant program and helping them to develop the skills that would be necessary for them to take back to help the transplant program within their centers. Just as with Trinidad, the charity has been very dependent on funding from various sources to help the missions to take place, to cover cost of flights, to cover cost of accommodation, transport, and so on. And so a key part of the administration, if you like, of the charity is to identify sources of funding in the partner center that will help support the missions. The volunteers are not paid. The volunteers go out from the UK without any payment, but clearly travel arrangements and accommodation need to be made. In this slide, you see one of the first of the transplant operations, the lady on the left, sister of the lady on the right, and she's the donor who's just returned from theatre, having had her kidney removed, and her sister shortly after was taken to theatre and had that kidney implanted. And I'm pleased to say they did very well. I was talking earlier to Mr. Haynes and to Keisha. We were talking about transplantation in Barbados. The charity has actually been communicating and visiting for about 5 years now, and there are plans for another visit early next year. And you'll see the same theme, which is of training that's provided in the UK for key members of the team. These are usually people who have some experience of transplantation and of working in a transplant program, and who require further training and increased experience in a bigger center. So we've had a surgeon visit here, the transplant coordinator, and a nephrologist trained in the UK for 2 years prior to returning to Barbados and taking up a consultant post. In addition, TLC have undertaken visits not only to review patients and potential donors, but also undertaken teaching in Barbados to talk to members of the transplant team, so theatre nurses, surgeons, medical staff, to talk about the protocols and the various techniques that need to understand, and importantly also to plan for a transplant, particularly to make sure that equipment and medication is available for that transplant to be undertaken successfully. So in 5 years, there have been 10 transplants undertaken with direct involvement of the charity. And at the moment, there are continuing plans for that link to be maintained. And we're very grateful to the support of Republic Bank, again, from the community program, which has been very important in supporting TLC's missions to Barbados. In this slide, you'll see the young lady who donated to her mother, the donor on the left of the picture and the recipient on the right, and the lady in the middle, Dr. Jirawan, was in fact trained in Birmingham as a nephrologist and returned to Barbados and is now one of the key individuals in supervising the transplant program. Obviously, this was a very big story. It was a very good news story that was publicized, and if you missed it in this paper, you might have come across the same story in one of the other publications that came about from their experience. And I think yes, it's a good news story. It's one that makes everyone feel great when they see it, but it's also the importance of this is really to publicize the success of transplantation and to promote transplantation and to encourage people to think about transplantation and to come forward to consider if this is something that might be for them. So that's a review of the charity in the Caribbean and a little bit about sort of background of the charity. Just going to move on to talking about more specifically about kidney donors and recipients. So I'm sure you'll be aware that broadly speaking, there are two sources of kidneys for transplantation. The first is living donation, and the second is deceased donation. And I'm not going to say really very much about deceased donation because as a charity, we've recognized that we're not really able to initiate and sustain a deceased donor program. The infrastructure required for that is far too great. And so we've concentrated on living donation. And there are various classes, if you like, of donor. There are people who are genetically related. So, for example, we saw a mother to son, we saw sisters. You can get more distant related, you can get grandparents donating, aunts and uncles and so on. You can also get genetically unrelated but emotionally related donation, and the first couple I showed you was a husband and wife. So these are genetically unrelated but emotionally related, and that can be a successful transplant pair. Now in the UK and in North America and other countries, there is a scheme called paired or pooled donation, which is not really something that's available within the Caribbean, as far as I'm aware, but it is a development of live donation that may well come about. And this is where a donor is unable to donate a kidney to a recipient that they would wish to donate to. And this might be for a variety of reasons, mostly to do with a lack of blood group matching or tissue matching. And so it's then possible to, if you've got a number of such pairs, to say, well, if you can't donate to the person you wanted to donate to, can you donate to somebody else, and can their donor donate to the recipient you were wanting to donate to? And so a swap can be made. In the end, everybody donates, everybody receives a kidney, but it's just not the person that you initially thought you were going to donate to. And this has proved to be really quite successful, especially for individuals for whom we have great difficulty in matching a kidney. And this is something, as I say, that although it's not available in the Caribbean at the moment, it may well be something, as you have more and more donors and recipients coming forward, it may be something to be considered. Again, in the UK and in North America and other the developed countries, we're finding we're getting individuals stepping forward and saying that they wish to donate. They don't have a particular donor in mind, they just want to donate a kidney into the pool. And this is called altruistic donation. In some countries, actually, this is quite an important source of kidneys, and there are some religious organization, for example, I'm aware of Buddhist monks, particularly who donate kidneys in this altruistic way, as they feel that that is how they can contribute to the benefit of their fellow men. So we thought there about who can donate. Well, who can have a kidney transplant? Well, really anybody who has advanced chronic kidney disease, and you may be aware of the classification of chronic kidney disease. Stage 5 is pretty much people on dialysis. Stage 4 is where you have level of kidney function severely reduced, but not bad enough to be on dialysis. So people who are on dialysis or even before dialysis can be transplanted. The main thing is that we need to know that this person has definitely got severe chronic kidney disease and it's irrecoverable. It's going to get worse and it's not going to get better either by itself or with treatment. It's of course very important that the recipient is medically fit for the transplant. And unfortunately, chronic kidney disease does lead to associated medical issues, particularly coronary artery disease as a result of high blood pressure, as a result of calcium and phosphate abnormalities. In addition, it may be, we know that a number of people with chronic kidney disease have diabetes, and you can have complications from that. So there are a number of medical issues that need to be considered before someone can go forward for transplantation. And there are very clear protocols for assessing a recipient as being suitable for transplantation. Of course, it's also necessary to have a suitable donor, and I've talked about deceased or live donors as a source of kidneys. And of course, the other important thing, particularly in low and middle income countries, is access to a transplant program. And it takes me right back to the beginning, which is where we recognize as a charity that access to transplant programs are limited, and this is a big block. And one of the key aspects of the charity is to improve access to transplantation and allow individuals who do not have ready access to a transplant program to perhaps be transplanted. Many of the individuals who've been transplanted with the charity's intervention have only been transplanted because of our presence and involvement. In the UK, the predominant source of kidneys, as I said, with deceased donors. But actually, for the last 20 to 25 years, live donor transplantation has become a very important source of donor organs. And now about 30% of kidney transplants in the UK are live donor. So although we had an active deceased donor program, a shortage of donor organs has led to the development of a very active live donor program. So live donation is now a very important component of the transplant program here in the UK. And all forms of live donation are offered, the ones that I mentioned. So why has the charity really focused on living donation rather than considering deceased donor, given that it was such an important part of the UK program? Well, I'm sure you'd appreciate that a living donor transplant is much easier to plan. We know the date of the operation, we know what will be required for the operation, we can make appropriate preparation in terms of medication, investigations, and so on. We can ensure we have the right staff in place, and all the facilities for a successful transplant. And of course, ensuring that the donor nephrectomy is undertaken safely. So it's that the logistics is very much easier. In addition, of course, it's possible to obtain the consent of the donor, and this is very important. And it's now there are well-established international guidelines, ethical structures, and legal structures to give guidance for live donation. On the other hand, deceased donor transplants are unplanned. Nobody knows when a suitable donor will become available. Everything has to be done in a big rush. And so logistically, it's much more difficult to plan for that. The legality of deceased donor transplantation is quite different from live donor transplantation. And of course, for some religious groups, and even for some individuals, there are ethical objections to deceased donor transplantation. So setting up a deceased donor program requires quite a substantial undertaking. And we know, if you look at the graph down here on the left, we know that if you look at the live donors, over time, more live donor kidneys survive than deceased donor kidneys. So not only is it an easier procedure to plan, but the outcome is better than for deceased donation. That's not to say that deceased donation programs are unimportant. They're very important, an important source of organs. And as I said, in the UK, deceased donors account for between 60 and 70% of all transplants. So it's very important. And of course, it's important for non-renal transplant programs as well. So deceased donor programs are important, but in our experience, they develop later as a transplant unit matures and progresses. So I think from our charity, the perspective that we have is we think that the live donation that programs that we've been involved in the Caribbean have been a great success, and so because of ability to plan for the logistics. It of course is important to ensure that the volunteers are available as well to go out to the partner center to support transplantation. And one of the things that we hear very often is that families want to help their loved ones who have kidney failure. They want to do something for them. They want to help them. And by going through, by successful transplantation and going through the donation process, they are able to contribute in a very, very significant way to the future of their loved one. The majority of donations these days, as I said, are undertaken using a keyhole technique, which means that most donors recover really quite quickly and are home within 3 to 4 days. Now, of course, as I said earlier on, successful transplantation requires a donor, and people will be asking, well, am I a good candidate? What makes me a good candidate? And fundamentally, we need to be sure it's safe for the donor to lose a kidney, and equally that the kidney will do what we want it to do for the recipient. And what we know is that over time, kidney function declines. So on this graph shows on the bottom axis, you can see increasing age, and on the vertical axis is the level of kidney function. And in the middle line is the average, and the dotted lines mark the upper and lower limits. of kidney function at different ages. And you see after the age of about 35 to 40, kidney function normally gradually progresses, but it doesn't progress to the level of chronic kidney disease. And so most people who are well do not have chronic kidney disease. And they are perfectly able to donate a kidney. So you can donate kidneys into the 70s, 60s and 70s, and we have donors donating at that age. Fundamentally, it's important to ensure that the kidney function is satisfactory and will maintain good function after a kidney is removed. And what this graph shows is there's a range of normal kidney function. So in deciding whether someone can donate, we're not so much worried about the age, but we're worried about the kidney function and whether or not that person's kidney function will be adequate to maintain their health after they've donated a kidney. So age is not a bar. You won't be surprised to know there's a very long list of things that have to be looked at before donation can proceed. What's very important is a blood group match. Now, here in the UK, it is possible to donate against certain blood group matches. This is called a blood group mismatched transplant. The technology for that, particularly the laboratory backup for that, is quite sophisticated. And so this is not something that at present is available in the Caribbean, but with time may well become available. But in the meantime, a blood group match is essential. We need to know about the donor's medical history, and there are various factors that you will see there that will be taken into account. Diabetes, for example, is a very important factor and often is a contraindication to donation. Other aspects such as smoking, for example, can be influenced by encouraging people to give up smoking. Excessive weight can also be a contraindication to donation, and so people may be encouraged to lose weight. We've certainly had donors who've been keen to donate, who medically can donate, but they need to lose weight first. Of course, potential donors need to have a physical examination and some routine blood and urine tests, various scans and x-rays. And another important test is the tissue type match, which is quite a sophisticated test, but it ensures that if there is a close match, it reduces the risk of rejection. And then very importantly, there's a psychological assessment, which ensures that the person who's donating the kidney really is convinced that this is the right thing for them. They want to do it, and that they're doing it for all the right reasons. I've shown you some pictures of ladies who have donated. And so, of course, for some ladies, the question will arise, is it safe to get pregnant after I've donated a kidney? So we know that high blood pressure and preeclampsia, which is a condition that can affect pregnant ladies who have high blood pressure, protein in the urine, that's a bit more common among living kidney donors, but in general, these symptoms can be managed and are not considered a contraindication after discussion. And so usually this is not something that puts people off donating. In other respects, if we look at premature births, low birth weight births, maternal deaths, stillbirths, and so on, there's no real difference with the general population. And we know now that most women who have donated have uncomplicated pregnancies and can have multiple successful pregnancies after donation. As live donation continues all over the world. More and more data is collected about the outcomes for the donors. And you'll see from this particular study that death directly attributable to donation is incredibly rare. It's 0.006%, which equates to over 1 in 16,000 operations. So the risk to the donor of dying directly as a result of donation is incredibly small. And even other complications are really very infrequent, and serious complications are very unusual after donation. So we know, and we have increasing data to show that live donation is safe and successful. In the long term, bearing in mind that live donation in large numbers has been going on for maybe 25 to 30 years, we're now starting to get some long-term data. There seems to be a slightly greater risk of kidney failure after donation, but we're talking 15, 20 years after the procedure. In general, studies have shown that living donors have a good quality of life, and very, very few donors subsequently have any regret about having been through the procedure and donated their organ. Now, we're very fortunate here in the UK that there are government schemes that help financially in the short term. Generally, people are asked to be off work for 6 weeks, and so there may be loss of earnings. We're fortunate that we have a scheme for financial support, and I am conscious that in other countries, particularly low and middle income countries, there may not be that same level of short-term financial support, which may be something that people have to think about. However, studies have shown that in the long term, there are no long-term significant financial consequences as a result of donation. So I think from studies and from our experience, we can say that living donor transplantation is very safe. It's certainly cost effective when you compare the cost of the transplant procedure and the cost of medication afterwards to dialysis costs. And we found that the outcomes for both donor and recipient are excellent. Live donation now is very well established, and there are very well recognized protocols and procedures that can be shared with partner centers to ensure that donation is safe and that the transplant procedure is safe and successful. And in addition, the logistics and the legal framework that's required is also very well known. And again, this is something that can be shared, and we as a charity have lots of documents that we're very happy to share with partner centers to help them along the way, particularly with regard to the legal side. One of the things that unfortunately we have seen in our the various centers that we visited is we do see a dropout of people from follow-up, people not going to clinic visits. And this applies to the recipient as well as the donor. And this is unfortunate because it is essential that both the donor and recipient have long-term follow-up to monitor their health and ensure that all appropriate steps are being taken to maintain a good outcome. And this is something that is for the local team really to address, but it is very important. And as I've discussed earlier on, we've consciously decided not to be involved with deceased donor programs because of the very substantial infrastructure, legal structures that need to be set in place. The success of our missions is entirely dependent on teamwork. In this slide, there are 3 members from the charity who have come along to help the nurses, surgical staff, theatre staff, and so on. But this teamwork is absolutely essential, and we are delighted that the sister centres that we work with, the centres we partner with, have been so enthusiastic in developing that teamwork and maintaining the teamwork. And really that has been key to the success of the program. So finally, this is the web address for the charity if you want to look it up. There are many volunteers and other people who are involved, some of whom are named here. But the link is at the bottom. And if you want to learn more about the charity, please do look at that website. That is me. Thank you very much.